Osteoporosis is a common disease that causes significant suffering and has considerable economic impact. Osteoporosis is characterized by low bone mass, disruption of normal bone microarchitecture with trabecular bone loss and increased cortical porosity, and increased skeletal fragility. The net effect of these changes is an increased risk of bone fracture. In 2007, the World Health Organization Working Group on the Assessment of Osteoporosis and Osteopenia published diagnostic criteria based on bone mineral density measurements. Their reference standard is bone mineral density of the femoral neck measured by dual energy X-ray absorptiometry or DEXA scan. Results are expressed as grams per centimeter cubed or a standard deviation from the mean compared to a reference group. For postmenopausal women, this is a T-score, and the comparison group is healthy 20 to 29-year-old women. For premenopausal women, men and children, Z-scores are used matched for age, gender, and ethnicity. A Z-score of less than -2 is indicative of low bone mineral density. DEXA measurements can also be taken from the total hip or lumbar spine. Lumbar spine measurements are subject to misleading findings in older women because osteophytes or spinal crush fractures may artifactually increase density. Therefore, hip measurements are preferred in the elderly. The WHO categories are listed in this table. Normal is a T-score greater than or equal to -1 SD from the mean. Osteopenia is a score between -1 and -2.5. Osteoporosis is a T-score less than -2.5. And finally, severe osteoporosis is a T-score less than -2.5 with a fragility fracture. A fragility fracture is a fracture that occurs in the absence of trauma or is caused by a fall from standing height or less. Osteoporosis affects more than 10 million Americans over the age of 50. The risk increases with age. Peak bone mass in women occurs in the late teens and early 20s when increased calcium reserve is needed for pregnancy and breastfeeding. During this time, women may lose 15 to 30% of vertebral density. Fracture risk in women increases approximately twofold for every standard deviation below the mean on the T-score. Females are affected much more often than males, and Caucasian women have a 50% lifetime risk of osteoporosis. About 20% of women aged 65 to 74 are affected. Hip fracture in the elderly is particularly dangerous. 20% of patients over 70 with hip fracture will die within 1 year, and 30% will have permanent disability. Screening for osteoporosis is based primarily on DEXA measurements. Central measurements are more accurate than peripheral site DEXA, although the latter is less expensive, more portable, and uses less radiation. Quantitative ultrasound is increasingly being studied as a screening test, but has not yet been validated. Biochemical markers of bone turnover cannot diagnose osteopenia or osteoporosis, but they can identify patients with high bone turnover. Therefore, they can be used to monitor response to therapy. So DEXA of the hip and spine are the gold standard for osteoporosis screening. Laboratory workup for secondary causes of osteoporosis include serum chemistry, including calcium and phosphate, 24-hour urine calcium and creatinine, parathyroid hormone and thyroid-stimulating hormone levels, 25-hydroxyvitamin D levels, and serum protein electrophoresis, which may be used to rule out multiple myeloma. The American College of Obstetricians and Gynecologists recommends screening all women greater than or equal to age 65. Postmenopausal women with one or more risk factors for osteoporosis and postmenopausal women with fractures should also be screened. Premenopausal women should be screened when they have risk factors for osteoporosis. The U.S. Preventative Services Task Force recommends screening all women greater than or equal to 65 years of age, women 60 to 64 with increased fracture risk, and states that there is insufficient evidence for screening women under the age of 60. There are many risk factors for osteoporosis. Many diseases and lifestyle choices affect the risk of osteoporosis, as do dietary factors such as low calcium and low vitamin D. Social factors such as low sun exposure, low body mass index, smoking, alcoholism, and lack of physical activity are also well known. In addition, many genetic disorders and medical conditions or their treatments have an impact on bone density. Validated risk factors independent of BMD include advanced age greater than 65 for women or 70 for men, previous fracture, long-term glucocorticoid therapy equivalent to prednisone 5 milligrams per day for greater than 3 months, low body weight, less than 127 pounds, family history of hip fracture, cigarette smoking, and excess alcohol intake or greater than 3 drinks per day. The most robust predictors are age and previous low trauma fracture. Specific risk factors in postmenopausal women are history of prior fracture, family history, Caucasian race, dementia, poor nutrition, smoking, low weight or low BMI, estrogen deficiency, low calcium intake, alcoholism, impaired eyesight, history of falls, and inadequate physical activity. In summary, osteoporosis has a significant impact on the health of our patients. As the population ages, compliance with screening guidelines becomes increasingly important. The WHO fracture risk algorithm can be found at the website on the screen.